Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. I'm your host, Dr. Becky Carson, pediatric nurse practitioner and associate professor at the Duke University School of Nursing. And I'm so happy to welcome you back to our Immunization Update mini-series in an episode where we will talk about vaccine hesitancy with a very special guest, Dr. Maddie Manfredi. But first, my disclosures. I do not receive any financial incentive to produce or distribute this podcast. This podcast is my scholarship and my personal approach to advocacy. So I want you to know that this podcast is free from any conflicts of interest and secondary gain that could limit the credibility of my work. I'm so invested in credibility that I have 2 independent peer reviewers evaluate each episode before publication to watch for potential bias, conflicts, and ensure the content accuracy of our topic. That kind of quality assurance doesn't happen in all podcasts, but it means the Peds NP is one you can trust. A link to the peer review process is in the show notes or on the Peds NP website under peer review. All right, let's meet our very special guest today and talk about vaccine hesitancy, what we as providers need to understand, and one approach to address it. I am so excited to introduce Dr. Maddie Manfredi, a pediatric nurse practitioner in Boston, Massachusetts, and my former student at the Duke University School of Nursing DNP program. Welcome, Dr. Manfredi.
Thank you so much for having me, Dr. Carson. I'm really excited to be here and talk about this important topic. I'm also happy to share that I don't have any disclosures either.
Wonderful. Let's get started with a little bit of background on the use of vaccines in the United States. Can you share some insights of this public health innovation and its U.S. and global impact?
Absolutely. Vaccines are one of the most impactful public health interventions we've ever had, both in the U.S. and globally. They've dramatically reduced serious diseases like polio and Haemophilus influenza type B. In pediatrics, we see this impact every day. Many diseases we vaccinate against are not things most caregivers have ever actually seen, which is a testament to how effective vaccines have been. Other vaccines help prevent common infections that can lead to sequelae, like secondary bacterial ear infections and pneumonia being caused by the flu. Globally, vaccines continue to prevent millions of deaths each year, especially in young children. At the same time, that success can sometimes make it harder for families to fully appreciate the risk of these diseases, which is where some of the challenges we're seeing now begin to emerge.
Yeah, definitely. I've noticed vaccine hesitancy steadily increase since the start of my career over the last 15 years or so. And understandably, there are historic reasons for distrust of government institutions and vaccines themselves that it's really important that we understand. There were events like the Tuskegee syphilis study that fueled widespread distrust in government and the healthcare system, predominantly from Black and other marginalized communities. And we all know the story of the fraudulent British study that was published in the 1990s, that was later debunked and retracted, that was trying to show a link between MMR and autism. So that study was manipulated by Andrew Wakefield for financial gain. And then here we are, we find ourselves in an increasingly polarized political climate, and the COVID-19 pandemic has further complicated an already brooding problem of misinformation and disinformation. Maddie, can you help us first by defining vaccine hesitancy and then help us understand why it matters and the implications of its rising prevalence?
That's such an important question. The World Health Organization defines vaccine hesitancy as a delay in acceptance or refusal of vaccines despite availability of vaccination services, highlighting that this is not primarily an access issue, but more about confidence and decision-making. And this has become a growing concern. In 2019, vaccine hesitancy was actually named one of the top 10 global health threats. And more recently, in 2022, we saw the largest sustained decline in global childhood immunization rates in over 30 years. So why does this matter? Because even small declines in vaccination rates can have real consequences at both the individual and community level. When vaccination rates drop, herd immunity decreases and the risk of outbreaks increases, particularly for infants and medically vulnerable children who may be ineligible to vaccinate. For highly contagious diseases like measles, we need very high vaccination coverage, around 95%, to maintain herd immunity. And when rates fall below that threshold, we start to see outbreaks. And the impact really goes beyond the individual child. These outbreaks can lead to missed school and work days, increased hospitalizations, and significant healthcare costs. They also shift public health resources toward outbreak response, which can take away from other important prevention efforts.
Thank you. That is a super important foundation for us to have. And I want to point out, too, that vaccine hesitancy is a spectrum that ranges anywhere from timing issues to a complete and total refusal of all vaccines. And things like a kid who wants to delay a vaccine because they got a big basketball game coming up this weekend and they don't want a sore arm for it. Well, that child gets classified as vaccine hesitant by this definition, but I think it's nuanced. And I think I'd also be lying if I said that I didn't have some hesitant feelings at times when I'm holding my babies and the nurse walks in with 4 syringes and they're going to scream and cry and they're going to have pain afterwards and I'll be caring for their post-vaccine fevers. And that made me nervous, but I've still accepted every vaccine on our schedule because the science is compelling. It just doesn't mean that I'm without reservation. So tell us, what are the ways that you've seen vaccine hesitancy play out in your primary care pediatric practice?
You're absolutely correct in that vaccine hesitancy exists on a spectrum, and I see it show up in a few different ways. More and more caregivers are wanting to delay, space out, or even decline certain vaccines. Some families come in feeling overwhelmed by conflicting information they are seeing online or hearing from others. I think it's really important to recognize that most hesitant parents are not actually anti-vaccine. They're just trying to make the best decisions for their child with the information that they have.
That's a great point. And I think that's an important lens of empathy that is essential for us pediatric providers to garner. Now let's move our conversation to your specific DNP project. Tell us, what was the problem you identified in your practice?
In our practice, we were seeing an increasing number of caregivers who had questions or concerns about vaccines, and this ultimately translated to our clinic's immunization rates. Specifically, our MMR coverage, according to the state's vaccine registry, was 86%. At first glance, 86% might sound relatively high, but as I just mentioned, measles requires about 95% community coverage to prevent outbreaks. I was very curious as to the main reasons why parents were declining vaccines, or specifically what questions they had. So the problem I identified was really twofold. How do we better understand caregiver concerns, and how do we support providers in having more effective, patient-centered vaccine discussions?
And I can attest that you had a methodical review of the literature that resulted in an understanding that there were actually multiple important evidence-based practices worth employing. Tell us what you found.
What I found in the literature is that vaccine hesitancy is very complex and influenced by things like individual beliefs, lived experiences, trust, and concerns about vaccine safety, effectiveness, and necessity. Because of that, it really highlights the need for tailored, patient-centered communication approaches. The most effective strategies tend to be multi-component, with a strong focus on communication. Some of the key strategies include offering a strong recommendation, asking permission to share information, respecting caregiver autonomy, providing clear and accurate education, and using motivational interviewing. And in many ways, motivational interviewing brings a lot of these strategies together. At its core, it's collaborative and patient-centered, and it emphasizes respect for autonomy and in building trust over time. One finding that really stood out is that caregivers consistently identify their child's healthcare provider as their most trusted source of vaccine information. and that relationship plays a significant role in their decision to vaccinate. So ultimately, the way we communicate really matters. There's strong evidence that provider communication style directly influences caregiver confidence and vaccine acceptance.
Yes, nursing has been identified as the most trusted profession year after year. And what I love is that echoes a life lesson that I teach my kids and other healthcare leaders every day. It's not just what you say, but how you say it. I have used motivational interviewing before, but most often in children and families with obesity to encourage lifestyle changes surrounding diet and exercise. Can you give us some more details on what that looks like with regard to vaccine hesitancy?
With vaccine hesitancy, motivational interviewing really shifts the tone of the conversation. Instead of trying to convince or persuade, the goal is to understand where the caregiver is coming from and work together toward a shared goal. In practice, it means meeting parents where they are and taking the time to understand their hesitancy rather than reacting to it. From there, we can offer clear, accurate information in a supportive way. That might look like asking permission to share information, using open-ended questions, and reflecting back what the caregiver is saying. For example, if a parent says they're worried about side effects, we might respond with something like, "It sounds like you're trying to weigh the risks and benefits for your child." From there, we can provide evidence-based guidance, but in a way that feels collaborative rather than directive. It helps reduce defensiveness, builds trust, and ultimately makes families more open to considering vaccination, even if they're not ready to say yes right now.
I love that. If you're motivational interviewing curious, I invite you to listen to our next episode of the Peds NP, where Maddie and I will do some live case-based role-playing with motivational interviewing. It'll help you understand perspectives and build scripts that can be helpful for engaging families and progressing a meaningful and therapeutic relationship. Okay, so you taught these skills to the other provider in your office and then set forth to make an impact on the MMR vaccine rate in your office. I loved your project because you had a really novel and arguably controversial approach to starting these conversations. Tell us about the Caregiver Vaccine Readiness Survey that you handed out to families before their well visits.
One of the key components of the project was the Caregiver Vaccine Readiness Survey, which was given to families before the visit. It was intentionally brief, and the goal was to proactively identify whether caregivers had questions or concerns about vaccines, and if so, what those concerns were. The survey included options like vaccine safety, side effects, effectiveness, and the vaccine schedule, along with space for free text responses. What made this approach a little different is that it shifted the timing of the conversation. Instead of waiting for concerns to come up in the visit, providers had insight ahead of time and could tailor their approach using motivational interviewing techniques. It also gave caregivers a structured, low-pressure way to express concerns, which helped make the in-person conversation more focused and productive. It also normalized having questions about vaccines. And I'll just note that this wasn't a validated tool. It was designed as a practical workflow-based strategy to support communication in a busy primary care setting.
Oh, Maddie, you know that I love this project, and I have really big feelings about how novel and groundbreaking this was in our current era. And what I really love about this is that it acknowledges that you're experiencing a problem in clinic, and there may be limits to the AAP recommendations for this presumptive approach to vaccines, where we're somehow supposed to approach every family with the presumption that they will accept vaccines. So instead of saying, "Do you want this vaccine today?" you're supposed to say, "Your child is due for vaccines today." And while recommendations for a presumptive approach have foundations in the evidence, this is, pause, I want to say this is Becky Carson talking now. I think that times change, and the polarized political climate and widespread misinformation that is so abundant in an era of the internet has undoubtedly impacted the relationship that families feel with these vaccines. And I want to be clear, I am not saying that a presumptive approach is bad. It is rooted in science. But I am saying that we should be open to understanding problems systematically and then changing our recommendations when new problems arises, research supports something else, and evidence points us in another direction. And the other part of why I get really heated about this is that so many of these children become excluded from practices because their parents have refused vaccines. So, because the parents refused vaccines, the child isn't allowed to go back to the practice for any other form of primary care. And that marginalizes an entire population of vulnerable children. It pushes children out of medical homes where they're now not getting supported in their other components of well care, developmental screening, health promotion, sports and school physicals, and other forms of disease prevention. I had a kid the other day who was in clinic who didn't have a primary care provider and they were excluded from a practice, and he had really marked and concerning developmental delays. He was 4, but had missed his MCHAT screening at 2, and therefore was missing all of that early intervention that would come with picking up on his delays early. And I'm not passing judgment in any direction, but I'm saying that if this phenomenon exists, then rather than excluding children from practice, we have to figure out solutions to care for them. Okay, soapbox is over. You are pretty used to those by now. Tell us what your convenient sample of caregivers had to say about their vaccine readiness.
So during the 12-week project period, we distributed 175 surveys and had a 92% completion rate, which gave us 161 caregiver responses. Almost a third of caregivers reported at least one vaccine-related concern. I think this is a notable proportion because without a tool like this, those concerns may not have been identified until later in the visit, or maybe at all.
That's incredible. 1 in 3 had a concern. And I want to pick apart some of this data because you know that I also love data. You had a 92% survey completion rate. And to me, that means that 92% of people wanted to have a conversation with you about this. And it yielded 161 children whose caregivers shared their vaccine readiness with you, most predominantly in infant and adolescent age ranges. Tell us about the caregivers who reported vaccine concerns and what their worries were.
Among the caregivers who reported concerns, the most common questions were related to the vaccine schedule and timing. So things like wanting to space out vaccines or better understand why multiple vaccines are given at one visit. We also had 28 caregivers who shared more specific or individualized concerns through the free text responses. Surprisingly, past experiences or personal belief concerns, such as religion, were reported the least often.
Oh, how interesting. And if I did my math correctly, of the caregivers who reported a concern, 78%, so 40 out of 51 patients, accepted vaccines, which really highlights the power of a therapeutic relationship with your healthcare provider. Yes, the sample size was small, but this has big ripple effect implications. And as my dad would say, more research is needed. And while we can't necessarily say that motivational interviewing was causative for vaccine acceptance, I want to highlight your successes in MMR vaccination. Tell us the impact of this project on MMR rates during the project period.
Yes, absolutely. During the project period, 14 patients were due for the MMR vaccine, and all 14 accepted vaccination, resulting in a 100% acceptance rate. When we look
Cheers to that. Congratulations.
Thank you. When we look at clinic level data, MMR rates increased slightly from 86% to 87% over the course of the project. It's important to note that the clinic level rate reflects a much larger denominator beyond just those seen during the 12-week implementation period. So while the overall increase was modest, the 100% acceptance rate, as the visit level suggests, that structured, MI-guided conversations may positively influence vaccine decision-making in real time.
All right. So, Maddie, what do you think are the implications of these results on your survey?
I think one of the biggest takeaways is that many caregivers are open to vaccination when they feel supported and heard. The fact that 32% of caregivers had concerns, but vaccines were only refused for 11 patients out of 51 concerned caregivers, 21% for those of you doing the math, really highlights the importance of the therapeutic relationship and how we approach these conversations. It also suggests that proactively identifying concerns and using a more tailored, patient centered approach may help move families toward vaccine acceptance. And while more research is definitely needed, these findings support the idea that small, practical changes in communication can have a meaningful impact.
Yes, absolutely. All right. You had another aim for your project. Tell us about it and what happened after implementation.
Yes, so the third and final aim of the project focused on improving documentation of vaccine refusals and using the AAP refusal of recommended immunizations form. Prior to the project, we weren't using this form at all. During the implementation period, the form was completed for 7 of the 11 patients whose caregivers refused vaccines, resulting in a 64% documentation rate. Refusals occurred across the pediatric lifespan, from infancy through adolescence. So this wasn't limited to one specific age group. And the most frequently declined vaccine was the seasonal influenza vaccine. Here's where it gets a little interesting. In 6 of those cases, caregivers declined all vaccines due at that visit. And in 5 of those 6 cases, a refusal form was distributed. So this suggests that providers were more likely to use the form when refusals were comprehensive rather than partial. Although we didn't meet our predefined goal of 90% documentation, this really highlighted some important workflow and implementation barriers.
Right. And yet another AAP recommendation that was really hard to practically implement. What do you think the barriers were to being successful in caregivers signing those refusal forms?
I think there were a few key barriers. Timing was definitely one, since these conversations can already be complex, and adding another step to the workflow can be challenging in a busy clinic. There's also the relational component. Asking a caregiver to sign a refusal form can just feel uncomfortable, especially when you're trying to build trust and maintain a therapeutic relationship. And then there are workflow factors such as remembering to offer the form, having it readily available, and integrating it into the visit in a way that feels natural. For me personally, the biggest barrier was the interpersonal dynamics of these conversations.
Yeah, that registers with me because the family is going to come back again in the next visit and you're going to have another vaccine conversation. And yet you've asked them to sign this refusal form that really maybe feels judgmental for them, and less about informed consent and more about personal opinion, even when it's meant to be objective. So it feels like you have yet another piece of evidence that tells us that times change and recommendations need to be reevaluated. How does this experience change how you think of the AAP recommendation for refusal forms?
This experience really made me think more critically about how recommendations translate into real world practice. The intention behind the refusal form is important. They support informed decision making and documentation, but in practice, they may not always align seamlessly with relationship centered care. I think it highlighted the need for flexibility and for thinking about how we can adapt recommendations in a way that still supports both good documentation and strong provider family relationships.
Yeah, for sure. The changing sociopolitical climate, a measles outbreak, and new vaccine schedules undoubtedly muddied the waters on motivating factors that were externally influencing the desire for vaccination during your project. But you showed that such a project is feasible in the regular workflow of your private practice without adding to the duration of time of an appointment. How has the sustainability of this project been for y'all? Have you kept up with the survey since the project data collection period ended?
That's a great question. We aren't currently consistently using the survey after the formal project period ended. I think that really reflects the realities of clinical practice and how sustaining a new workflow requires ongoing reinforcement. And without that, it can be difficult to maintain consistency over time. With that said, the project still had a meaningful impact. Even though the survey hasn't been consistently used, I've continued to incorporate motivational interviewing into my conversations with families. And that's really changed how I approach vaccine discussions. I think moving forward, sustainability would depend on integrating the survey more formally into clinic workflow, such as incorporating it into the electronic health record, or even simple strategies like laminating the survey so parents can quickly complete them and we can reuse them.
Yeah, that's a great idea. I've seen flashcards on a key ring that families can select their current vibes on discussing controversial topics that day. So you leave them with the key ring of emotions, and then they leave on the counter the ones that fit for them that day. Like, I have questions, or let's talk about safety, let's talk about timing, or even let's talk about this at our next visit. I want to thank you so much for doing such an interesting project, inviting me to be a part of the journey with you, and sharing your scholarship with us today. What do you want the listeners of the Peds NP to take home with them after listening to your project results and conclusions?
I think the biggest takeaway is that how we communicate with families really matters. Most caregivers want to do what's best for their child. And when we approach these conversations with empathy, curiosity, and respect, it can make a meaningful difference. I also think that in today's pediatric primary care setting, we really need to show up as partners, working with families, not just directing them. Even small challenges like using a more collaborative communication style can help build trust and support vaccine acceptance. And ultimately, that's what this work is all about, supporting families and protecting the health of the children we care for.
I want to thank you again for being here, Dr. Manfredi, and personally congratulate you on your recent DNP from the Duke University School of Nursing. I look forward to seeing you at commencement. I'd also like to invite you to stay with me for the next episode, where we'll learn a little bit more about your motivational interviewing strategies and do a little bit of role playing to get some practice for those crucial conversations in clinic. Maddie has left us with a number of references in the show notes, and you can find even more at thepedsnp.com. I'm on Instagram at thepedsnppodcast, or you can email me directly at thepedsnp@gmail.com. All right, I'm Becky Carson, and I'm going to let Maddie sign us off this time.
Don't forget, this isn't just a podcast. You're building trust with families one conversation at a time.